RSSDI TV 2020 brought to you by Wockhardt. I am Dr. Ruchi Shah, and on behalf of Wockhardt RSSDI 2020, I welcome you all. I am glad to have with us today renowned and eminent personality, senior endocrinologist from Mumbai, Dr. Shashank Joshi, sir. Sir is a senior consultant endocrinologist and physician at Leelavati and Bhatia Hospitals and Joshi Clinic and Dean at Indian College of Physicians. He is also the chairman of IDF Southeast Asia, and he has been the recipient of the prestigious honor of the Padma Shri Award. Welcome, Dr. Shashank Joshi, sir, to the show.
Namaskar.
So, sir, we are well aware about the challenge the COVID-19 pandemic has caused to the humanity, and there also exists a connection between diabetes and COVID-19 infection. So, based on your recent talk on a very relevant and current topic of interest, which is the global and Indian implications of the COVID-19 on diabetes, we will first like to know from you, how do you perceive the bidirectional association between diabetes and the COVID infection?
So COVID is a disease which is caused by SARS-CoV-2, which is the RNA virus, which is predictably unpredictable. But in that connection, on the pecking order, many people get asymptomatic disease, but some people get severe disease and they can die. So in the mortality or severity of the disease, there are vulnerable groups. And the top of the list on the pecking order is diabetes, right up there. Okay, of course, you have hypertension, heart disease, age, any chronic illness, but diabetes with hypertension is top on the pecking order, particularly from India. Like, for example, in the city of Mumbai, where I live, we know that almost 50% of deaths which occurred due to COVID-19 unfortunately happened in diabetics. And they were either hypertensive or diabetics, 50-50. So that's the impact of diabetes. Now, there is a bidirectional impact. If you are a diabetic and you are more vulnerable to get coronavirus, because when you are uncontrolled hyperglycemia, glucose, when it is high, it's a perfect culture medium for any microbe, whether it is a fungal infection, whether it is a viral infection, whether it's a bacterial infection. Diabetics get a lot of fungal nail infections, genital infections, mycotic infections. They also get a lot of sepsis. They also get urinary tract infections. Similarly, they are also vulnerable for pneumonias, including SARS-CoV-2 and flu viruses. So this is a susceptibility. So that is a diabetic person who is particularly uncontrolled is more vulnerable to get a COVID infection. Second is COVID per se docks through an ACE2 receptor in the lungs, in the gut, in the pancreas, in the kidney, and many other organs of the body, including the heart. Now, pancreas is a particular site where it docks, and you get an entity like a sudden development of diabetes there. They have no history of diabetes, no family history of diabetes. They were absolutely okay. Last year, they had done their A1C, it was normal. And suddenly you see that they have developed diabetes. It's like COVID diabetes. So there are 4 challenges. Diabetic patients are more vulnerable to get more severe disease of corona or COVID-19. Second is, with COVID, the SARS-CoV-2 can induce a pancreatopathy, which can cause a COVID diabetes. Third is you can get stress hyperglycemia. And finally, you can also get a diabetes due to the drugs which we give. For example, the only drug which makes an impact on mortality of severe or hospitalized COVID with moderate to severe COVID who need oxygen is steroids. And when you give steroids, again, if somebody is not a diabetic or is already a diabetic, there is a sudden surge of sugars and you often need to use insulin. So remember that once the patient is hospitalized, we give insulin. Otherwise, we are able to manage them very well. So COVID and diabetes is a deadly twin.
So what, according to your observations, will be the global and the Indian implications of COVID-19 on diabetes mellitus?
So I think the global and Indian implications are similar. That diabetes care has been circumvented because everybody is busy with COVID, and non-communicable diseases often get a step-motherly treatment. And among the non-communicable diseases also, heart disease gets a first priority, diabetes gets a second priority. We all know that diabetes is equal to a heart attack. But unfortunately, when you get a heart attack, you will have 20 relatives. When you get diabetes, you get 20 opinions from 20 people who all have their little own home grandma remedy. So obviously, diabetes is not taken as seriously as a disease, though it is equal to a heart attack. And now with COVID, there is so much of COVID phobia that everybody is focused on COVID and they forget about diabetes. So I think we need to refocus in the non-COVID care. We will have a tsunami of uncontrolled diabetes and diabetic complications. We shorten the diabetes lifespan. So we need to be very, very aggressive in controlling diabetes through digital diabetes pathways. because we can manage and do diabetes care digitally. We can remotely connect with people and manage diabetes. So in COVID, you need diabetes vigilance, and we need to supervise the diabetics so that they can live long and they are protected. They self-protect themselves, and also they are able to handle themselves better.
Thank you, sir. So what do you think is the latest update on COVID treatment and COVID outcomes?
So let me tell you two things, Dr. Ruchi. One is that diabetic drugs itself might have some anti-COVID roles, but they are all repurposed drugs. So metformin can have an anti-COVID effect. And for example, pioglitazone can have anti-COVID effect. SGLT2 inhibitors surprisingly might have some anti-COVID effects. There's a trial going on dapagliflozin on that space. Then of course you have the liraglutide and other GLP-1 analogs. But the drug for COVID, once the patient comes to hospital, is glargine, glargine, and glargine, because you need some insulin on board. So remember, if a patient is hospitalized with COVID, give them insulin. Don't fear insulin. Okay. Otherwise, you can give all anti-diabetic drugs and continue those anti-diabetic drugs later. But the treatment of COVID is predictably unpredictable. For asymptomatic mild disease, all you need to do is monitor the oxygen saturation, watch for the weak second, and virtually whether you give treatment or don't give treatment, nothing really happens. Person is going to recover. But we need simple markers. For example, if the red cell width is more than 14.5 in a simple CBC, we know this person is going to progress. If the person is elderly, hypertensive, diabetic, then person is going to progress. So in them, if you get the person early, and nowadays, of course, we don't use, this is a research tool, the cycle threshold value of RT-PCR of SARS-CoV-2. If it is below 24, and if you get the patient in the first 72 hours, if you use oral favipiravir, it works. It clears the virus faster. It may not impact mortality, but clears the virus faster. So favipiravir is an agent which is used. Some people have used doxycycline ivermectin, experimental. Some people have used hydroxychloroquine, azithromycin, more or less out now, it's experimental. If you get into the hospital, you can give injectable remdesivir. Again, experimental, data unknown, may not impact mortality. So pretty much everything in COVID care is empirical, is under research mode. But if the person comes to the hospital, the simplest test to monitor at home or in hospital is to do a 6-minute walk test with oxygen saturation. And if there's a drop of 3% on oxygen saturation, or if the oxygen saturation is below 94%, then you need to give oxygen with a prone position. That works. High flow nasal oxygen with prone position works. And if still the patient keeps on deteriorating, then you might need to give mechanical ventilation. Sometimes their monoclonal antibodies like itolizumab or tocilizumab can work, but that is rare. Beyond that, what really works when you oxygenate the patient is steroids. Dexamethasone 6 mg has been shown that it can alter the outcomes in COVID patients. Beyond that, often we give, the D-dimer is high, then often we give a low molecular heparin or an antiplatelet with a statin, and these all are supportive care. So COVID care today is all about supportive care, prone position, oxygen, and in severe oxygenated cases or ventilated cases, it's about a little bit of steroids. That's where it stands. Everything else pretty much is experimental. It will come and go, come and go, come and go, but it is hit hard, hit early. And he tried to give all medications of unproven value in the first week, because that's the time the virus is actively replicating for the first 9 days. After which it's very difficult. It's only probably steroid which will work once the immune response sets in. Okay, there's some thought about plasma, but plasma therapy has not shown the test of time in RCTs. But again, plasma, if you give in the first 7 days with a properly neutralizing antibody, it may work. But again, all these are compassionate therapies, experimental therapies, research therapies. It has to be individualized care, supportive care, and the most important thing in COVID care is comorbidity care. Manage your blood pressure well, manage your diabetes well, manage your heart disease well, and any other comorbidity well. So if you manage diabetes well with insulin, manage blood pressure well with ACE or ARBs, manage your heart disease well with some antiplatelet agents, you can have an excellent outcome with COVID and diabetes. So I think we need to save lives and we need to reduce our case fatality rate. And in that endeavor, I think handling COVID with diabetes is equally important, because both of them have a bidirectional impact on each other. And that's why it's very important that our diabetics are protected from COVID. Also, one more important thing you should remember is all diabetic patients, because it's COVID time, must take their flu shot, must take their pneumococcal vaccine. It's very, very crucial and important to recognize that. Of course, we will have COVID vaccines coming up, but that's a scope for another discussion.
Thank you so much, sir. So, sir, lastly, what are the key messages which you would like to share with the practicing physicians and diabetologists watching the RSSDI TV 2020 on managing the patients of diabetes with COVID?
So I think you need to be safe. You need to be self-protected. We need to have a COVID appropriate behavior of strict masking, strict social distancing or physical distancing and sanitization. That's a mandatory thing. You can do a lot of gargles also. There is nose COVID, throat COVID, lung COVID, and lung COVID on oxygen and on ventilator and so on and so forth. But most of the COVID will be mild, manageable and will recover. But if the person is a diabetic, needs more scrutiny, more vigilance, needs better diabetes care and better COVID care. So if you have a COVID with diabetes, you need to put down your specs and be vigilant and focus on the patient. Don't take it lightly, whether it is the first week, second week, or third week. Now remember, even though I sound scary, most people with diabetes with COVID have survived and they have done well, but we need a lot of vigilance in them.
Thank you so much, sir, for sharing your views on this important topic of global and Indian implications of COVID-19 in diabetes. Stay tuned to RSSDI TV 2020 brought to you by Wockhardt for such more recent and relevant updates from the RSSDI 2020. Thank you very much.
Thank you.
Thank you, sir.